Thank you so much for the kind introduction, and thank you, Dr. Jasia, for the invitation. Now that we are neighbors, we will see more frequently. So it's the first time that I drove from Columbus. It's very nice. Remind me a lot to my born country. I was born in Argentina, and these fields are very similar in the trip. So it was really nice to see. So we will discuss about ASCO 2024, but in the last year, this year, we have different congress that were giving a lot of evidence of robustness of the data that we will discuss. So I was mixing some of the information with the World Lung Cancer and with ESMO as well to give some context, because if we analyze only ASCO was a little bit not so great ASCO for us in lung cancer, we would say. It was more when we put all the data together. So let me see if it's working. Down, okay. That's my disclosures. So that's the agenda, but I will not cover all of that because we will stay here. I know that you want to go home. It's Saturday afternoon. But some of these we will go very quickly, but are very important information. So going to adjuvant setting in non-small cell lung cancer, we have historical clinical trials that you see there, the Empower 110, the PERS, and the B31, using three different compounds, atezolizumab, pembrolizumab, and durvalumab. And we will analyze these three clinical trials because we have different, they are very similar in different drugs, very similar, but there are also similar in endpoints. So we have disease-free survival as a primary endpoint, but there are some important differences in the trial when we are analyzing. So the disease-free survival of the first one, of the Empower 010, is the stage, for stage 1 and 2, is with the PD-L1 more than 1%. The keynote, the disease-free survival, is for the overall population and also in the PD-L1 more than 50%. And finally, the B31, that is a little bit more awkward how we are stratifying the patients on more than 25%. That is not a clinical stratification that we are using in our clinical practice. So if we are looking, for example, the Empower 010, in ASCO 21 was presented this trial, where stratified patients using the classification of 7, so we are now in the 8 classification, and we have there the stage 1B, tumor of more than 4%, and in the stratification factor were for stage 2 and stage 3. We have also there differences in the kind of antibody that was used to perform the analysis of the PD-L1, and the ITT population specifically was stage 1B, 3A. We are looking at the 5 years that was presented this year in ASCO, 5 years overall disease-free survival. There is an important maintains still of the results, 0.70 the hazard ratio in stage 1 and 2, in PD-L1 more than 1%, increased that obviously when we are going to face the PD-L1 more than 50% with a hazard ratio of 0.48, and when we are looking for in the population in EGFR and ALK negative, that was not done in all the patients, in this specific stratification, 0.49 hazard ratio. So, and we see here the difference between in 5 years of the curves, 45 versus 60, 66%. Very interesting division of the curves in this population. In the overall survival, we maintain, you see that it's very similar what we see in the disease-free survival and the overall survival in terms of benefit. And if we are looking what happened in these patients, specifically in the more than 50% without EGFR and ALK translocations and ALK mutations, you can see here that the majority of the patients, when they have a recurrence, they have a recurrence locally, and that was the patients who were receiving atezolizumab. But when we are looking in specifically the distant recurrence or the CNS, only majority of that were occurring in the patients that were not receiving adjuvant treatment with atezolizumab. So the important protected maybe activity in CNS and also in distance metastasis. In the PERS study, we don't have any update, but it's important to put here that we have a benefit in this in disease-free survival across all the groups, specifically obviously in patients with received chemotherapy before, that is a hazard ratio 0.80, And if we are looking this trial, that is the one that was presented this year at ESMO, the BR31, that I say that was a little bit awkward, the 25% PD-L1 difference that we are using for the stratification, they are using durvalumab versus placebo. And what we see here, that in this disease-free survival is really not a great benefit. There is no benefit, actually. So 0.93, the hazard ratio, so very bad for these patients. And if we are looking at dissected what happened in the 3 different trials, we see that there are differences in patients' characteristics. So the IMpower 010 was mandatory, the chemotherapy. In the other 2 trials was not mandatory. In this first trial, we also were not permitted to use carboplatinum. We need to use in these patients cisplatinum, and it's not fit for all our patients. And the difference also in the tumor characteristics, how we are, as I say, how we are using the antibody for the detection of the PD-L1. The SP142 was the use in IMpower 010, and then changed for the SP263. But also there are differences in the quantity of squamous population, 28% in the last study, so less squamous population, and that could explain some of the difference in the benefit that we see compared with the others. And the difference in resected population, 40% of stage 3 in the first study compared with the others. So you see that there are differences, and also non-smoker in the first study, that we know that the smoker population could have a better benefit, was only 23% compared with the others that have a higher rate of this population. In neoadjuvant setting here, we are complicating the things because we have several options. It's like a kid in a candy shop because we don't know which kind of candy we need to select, but the important is that we have different options. And I want to put together these 2 trials that were presented in ASCO in ESMO this year. I think it was very interesting to see this comparison in 5 years, what happened with the addition or not of nivolumab and ipilimumab to nivolumab. And that are the 2 studies, the NeoStart, that was using in stage 1 and stage 3, and 2 single station that was using the classification 7. And here we have the nivolumab at 3 milligrams day 1, 15 and 21 and 29, compared with nivolumab at the same days and ipilimumab. And the other study, that is a study of Patrick Ford, that is the CA 209-159, and this was also using a sequential enrollment in this population, using nivolumab in 2 different versions or 2 different dosage, day 1 and 15, and day 1, 15 and 29, compared with the also when the second arm was the combination of nivo-ipi in this population, following by surgery and following by a standard of care adjuvant therapy in these patients. What we saw here in the 5 years outcomes, that there are a benefit in nivolumab compared with nivolumab ipilimumab in this, specifically in disease-free survival and in overall survival, 65% compared with 52, and 83 compared with 69 in this specific analysis. So I think it's interesting. We cannot compare clinical trials. Obviously, it's not something that we want to have. We want to have head-to-head, but at least having these trials that were very similar, have an idea, because the numbers were very low in number of patients, putting together, we can get a better understanding. In the NeoStar, in this also, in this, if we are looking specifically the difference in the population in the 2 studies, or in the 2 populations, Nivo, the population who received Nivo and the population who received Nivo-ipi, we see that there is a favor for Nivo specifically in the for Nivo-ipi in the population with the squamous. That is normal because we are actually doing that in some specific populations. But and also was an important in the MPR in these combinations. But if we are looking specifically in the PD-L1 status, the PD-L1 status more than 1% or less than 1% were benefit with nivolumab alone, and the KRAS population, interestingly, was worse for both populations, for Nivo alone, so the combination of Nivo-ipi was a better opportunity for the KRAS mutation patients. If you are looking at pathological complete response, a major pathological response, there is an benefit in EPO and NIVO, so 28.1 versus 8.3, and the combination was better, 33.3 compared with 26.7. So several questions is coming for this analysis. From this analysis, we don't know actually which one is the better, but I think with this we can start to foresee which kind of population could be better. So KRAS, squamous, compared with the others and the PD-L1 status. So what is important that if we are analyzing, and this is a busy slide, all together the data, all the major trials are giving surgical response in this. So we have a pathological response in this analysis. It's an easy approach that with plus or minus differences is an approach that is valid and for the reason we are using in clinical practice. And if we are looking across the pivotal trials, the hazard ratio is very similar. We have an equilibrium. We have 0.59 and 0.69 in all the three trials, including the trials, the analysis of the long-term analysis of the CheckMate 816 that were presented in ASCO this year. And that's are the trials that we have in perioperatory setting, are very busy. We have AEGEAN, other trials, the RATIONAL, the NeoTORC. I will not discuss in particular of each one because it's a long time, but we received this year in World Lung Cancer 24 the data of the AEGEAN trial that is using chemotherapy plus minus durvalumab, followed by adjuvant durvalumab, and the data prolonged of 3 years demonstrate a benefit in disease-free survival, and in overall survival there is still a benefit that you see there with a hazard ratio of 0.89. So we will see what happens when these data are mature at 5 years, but seems that they are very positive in general. In the AEGEAN trial, what is interesting also that we see that the liquid biopsy, the ctDNA, have an important role to understand which kind of patients are responders. So if we have a clearance of the ctDNA, these patients are responding. And that is confirming what we see also in advanced disease in immunotherapy with this clearance of the ctDNA. That is more or less the paradigm that we have nowadays in early stage, very complex. We will be several trials coming because we are still debating which kind of patients are the best, what we need to do, for example, with patients with major pathological complete response, major pathological response, but they don't arrive to pathological complete response. So that's still the question. Duration of the treatment as well. So you see that the landscape is becoming very busy. This is in World Lung Cancer, was not in ASCO, but I think was a very interesting data coming from this compound. This is a compound from China that is an anti-PD-1 and anti-VEGF. It's a dual inhibitor, and it's called ivonescimab. Ivonescimab was here in this study using in stage 2 and stage 3B, according to the 8 classification, so the new classification, and with EGFR and ALK negative. These patients are not receiving any prior treatment, and they have the comparison in 2 arms, or randomization in 2 arms, of the Evo alone versus Evo and chemotherapy, followed by surgery and followed by the maintenance of this compound. There are some, obviously the numbers are different, 11 patients in the monotherapy, 49 patients in the combination, but what is interesting to see that here we have pathological complete response, 30 and 43% in both arms, and there is also a residual vital tumor areas that are 50% and 69%, so very interesting data, including complete response like you see there, and also an impact in the disease-free survival. There are still questions here, what happened in the, because we are working with a drug that is also an anti-VEGF, what happened with central tumors, with cavitations, there are more risk or no, what is the specific toxicity in this population. If we are moving to locally advanced disease, here we have, we know that the Pacific, and that are data, all data from the JCO 2022, that the maintenance with durvalumab after chemoradiation are impacted in progression-free survival and in overall survival, and that's are the 5 years data. And we know that there is an unmet medical need in patients who have targeted therapies. And this is the post-hoc analysis only for EGFR mutation, but we know that in different tumors with different characteristics, and was funny to hear that the former chair of the former session say a very rare disease, lung cancer, and it is, because we have more and more stratification of different populations. It's a big family name, but a very difficult to handle family because we have different alterations. So what we saw with this patient with EGFR alterations, with durvalumab, they are not doing well. So this year we have in ASCO the presentation of the LAURA trial, that is in patients who are locally advanced and resected stage 3 lung cancer, EGFR mutated, with not progression during or following the chemoradiation definitive treatment. They were receiving randomized osimertinib, randomization 2-to-1, because we know that it's important to give a maintenance to these patients, versus placebo. And the primary endpoint was progression-free survival by the independent review committee, RECIST version 1.1, and the secondary endpoints overall survival, CNS, CNS PFS, and safety. What we saw here is something that is unbelievable, I would say, in lung cancer, because we was very happy to see this data in stage 3. You have a possibility to impact clinically in progression-free survival with a hazard ratio of 0.16. So this is really unbelievable in lung cancer. In other tumors, it's easy to see, maybe, but in lung cancer, as I say, was something that is a new achievement. Actually, FDA, these data were presented in June, FDA approved this, the osimertinib in this population in 25 September of this year. So we have this available now, and I hope that we are not delaying a lot to have other biomarkers coming, because it's very important. So what we see also, and that is data from the last year, ESMO 2003, that there is a protective action with the in brain, specifically the cumulative incidence to distant and non-distant metastasis, and specifically, as I say, in brain, seems there is a very important activity to protect these patients who have a recurrence in the brain. So in metastatic non-oncogenic addicted, we have obviously historical trials that are the EMPOWER, cemiplimab, the atezolizumab, and the IMpower 110, and the KEYNOTE-024, and in pembrolizumab with impact in 5 years in overall survival. What we saw this year also is the addition of the same drug that I spoke before, the Chinese drug, that is called Evo, I will say Evo because otherwise I will start to have problems. So in this population, in this case, stage 3B and 4, randomized 1-to-1 patients who have, this is first line, so that was compared a head-to-head of Evo versus pembrolizumab. So this is one of the questions that always we have, what we want to have this kind of trials compared with the standard of care with the new drug. And the new standard of care, because several times we have, still we are comparing, and we will see in second line, and still docetaxel is there. In this analysis, in this study, the primary endpoint was progression-free survival and secondary overall survival in this population. Progression-free survival, very interesting here, also has a ratio of 0.51 with an impact in 11.14 months versus 5.82 months, and demonstrated this an important activity with 5.3 months of ganancey of Evo versus pembrolizumab. We don't have, obviously, we are waiting for this. There are several questions about here. There are several questions about here as well, because it was a Chinese population, was not the trial is running. Actually, there are 2 different trials actually running here in United States. And we will see what happened also in the overall survival with these patients. The other study that was presented in World Lung Cancer this year is the TROPION-1, and I think this is a very interesting trial. This is data, the same that Dr. Davidson was presented before in breast cancer. And this obviously, and one of my colleagues there, Dr. Jay, say data is chemotherapy. Yes, it's chemotherapy with an antibody-drug conjugate that have a chemotherapy, and we are analyzing here the new ways to see chemotherapy with antibody-drug conjugates. So we don't need to forget that. I think was a very nice comment. So when we have data compared with docetaxel, this is in patients that were stage 3B, 3C, and 4, performance status 0 to 1. So this is important always to check this kind of population. Progression-free survival was the primary endpoint. Dual primary endpoint was progression-free survival and overall survival. And if we see here, the progression-free survival is impacted. We have a progression-free survival of 4.4 versus 3.7, and we have an overall response rate that is high. We have 26.4 versus 12.4 and 12.8. So this was very, I think these were very interesting data for this analysis, but unfortunately, overall survival negative. So you see here, the hazard ratio 0.94, 12.9 months versus 11.8 months, so not really an impact in overall survival, and is pity. So if we are looking at the overall survival in different stratifications in histology, by histology, seems to be that there is a benefit in non-squamous, and this is 0.84, 14.6 months compared with 12.3 months, but even though the ganancey is not so high, and in squamous, 7.6 versus 9.4, and here obviously the hazard ratio is negative, is 1.32. In metastatic, in oncogenia, were also some data coming from the 3 Congress. We need to remember that we have a population, as I say, that is a rare population, different tumors with different characteristics, and in patients even smoker, never smoker, former smoker, we have different characteristics. If we see, for example, KRAS here, don't forget that 9.1% of the KRAS patients are current smokers and are never smokers, compared also with the current and former smokers. So for this reason, never follow a test according to the clinical characteristic of the patient. Test all the patients. That's the clear message of this slide. If we are looking for the characteristics of KRAS, KRAS is present in different tumors. There are different mutations. We are focused on the 12C. There are also differences in ethnicity here, because it seems that the 12C is much present in the Western population compared with the Asiatic population, a difference of other biomarkers. But we are focused only on the 12C. There are now, I will not talk about the new inhibitors that are pan-KRAS that are coming, but I want to focus in the 2 drugs that we have in second line that could be a paradigm for changing. The one study is the 2 phase 3 study, the CodeBreak 200, that is sotorasib versus docetaxel. We want to right away from the docetaxel for the toxicity, but it's still our standard of care, and it's a drug that unfortunately with the toxicity is still active. So the overall response rate here in this study was 28.1% versus 13.1%, so it's in this population active, is approved, we can use. The median progression-free survival is showing a marginal benefit because it's 5.6 versus 4.5 months with a hazard ratio of 0.66. And we cannot really still understand better, we need to understand a little bit better for the censoring and the overperformance control group that we have here. If you are looking at the other trial that was presented in ASCO this year by Tony Mock, that is the Crystal 12, this adagrasib versus docetaxel. And here also we see progression-free survival as a primary endpoint. There is a clear benefit, 45% versus 30% in the 6 months already in progression-free survival, and in benefit, 5.5 versus 3.8, and a hazard ratio of 0.58. So very interesting data, and the overall response rate in this case is 32%. There are new drugs that I'm not discussing here. Divarasib is another drug that is showing, was also published in New England Journal of Medicine last year with a big important activity in different tumors of KRAS, so it's important to keep in the radar because we will hear more about this drug. But this year was presented other Chinese drug that is in ASCO, that is the Crocus trial, and the drug is fulserasib. And we revival, or we have a Lazarus effect of the cetuximab that we left in the past several years ago for non-activity in lung cancer, completely so activity that was, I would say, some activity in progression-free survival, not in overall survival. So the combination of this in KRAS 12C mutated in first line, this is a very interesting study in first line, primary endpoint overall response rate, secondary endpoints progression-free survival. We see that 33% of the patients have at least one available post-treatment tumor assessment, and the overall response rate 81%. So it's very, very high in this combination, with a disease control rate of 100% and with an activity in the brain of 70% in overall response rate. So very interesting data, very, I would say, appealing data. But are we able to go to first line with this kind of inhibitors, grading away from immunotherapy when we know that the benefit of KRAS in immunotherapy is there? Even we are able to go out from chemotherapy, because in this case, I remind you that we are not looking even the PD-L1 status of these patients. Another study in going to other biomarker, we back to EGFR mutation. We are using amivantamab in our clinics, and we know that one of the most important problems is the infusion reactions. So trying to improve that in our patients and having a better adherence to the treatment, the company was looking for another solutions, and that is the subcutaneous amivantamab. And that is the study, the Paloma-3 studies, that the design and overall response rate were presented in ASCO this year. And they compare a head-to-head between the overall, infusion, intravenous infusion versus the subcutaneous infusion of the combination of AMI plus lazertinib. In this case, the primary endpoint were more related to pharmacological activity and concentrations. But we see that the overall response rate, the complete response, and the disease control rate were very similar in both arms. That is not a surprise, but it's good to know. And finally, if we are looking at the progression-free survival and the overall survival, seems that there is a benefit, but I think we cannot really compare. It's nothing that is really impacting in our clinical decisions having one or other, because if we look for the World Lung Cancer data, World Lung Cancer 24 also data on the exploratory analysis, we see that that is the most important. The infusion reactions are super less. We have some local reaction of the injection site. There is also a venous thrombosis effect that is less. That is also very important. And there is obviously a patient convenience and a patient satisfaction that is impacted in these patients. In World Lung Cancer also we have the data of some data that I think are important for our hospital in metrics, that are the patient time in the chair, and also especially for patients that they can go home quickly, and also the utilization of our resources in the clinics that are obviously impacted in a positive way. Other trial that was also interesting in ASCO this year is the Luminosity trial that was presented by Ross Kamich, and this Teliso-V. This is also an antibody-drug conjugate. It's a first-in-class c-Met antibody drug conjugate that is killing the cells using obviously the payload that in this case is called monomethyl auristatin E, or MAA. And that is, this trial was showing an important overall response rate in overexpression. So overexpression, back to the landscape of lung cancer. Some years ago, just to do a little bit history, we have a trial that was using onartuzumab, that was another drug, using overexpression and EGFR mutation in that case, were negative. We don't back to that c-Met, but now overexpression, but now we are using overexpression, and you will see that there are several companies focused on that. and overexpression and amplification as well, but not as a mechanism of resistance, but as a primary endpoint. Actually, I'm the principal investigator of one of the trials that is the lung map that was launched this month, that we are using amivantamab in high amplifications of c-Met as a primary endpoint, as a primary driver, sorry. We see here the overall response rate in high intermediate that is consistent, 34 and 22% of these patients. Number of response, and also the most important part is that the time to response when they start to have the response was very short, 1.4 months in this population. The CROWN study going to ALK inhibitors, we know that this that was presented some years ago, and we know that this is an option that we have today. But these are the analysis of the 3 years presented this year in ASCO, and the 5 years. The 5 years presented this year in ASCO. You see 64% at the 3 years. We have here a number of hazard ratio that is also very good, 0.19, but we are compared here with crizotinib. That is not our standard of care anymore. So we are using alectinib as a first line, or other drugs. We have brigatinib, we have also other options. But it's interesting to see, obviously, the 5 years, also activity in the brain that we know that is there. And if we are looking for, this is not presented in ASCO, but just to make a little bit the point, remember when we have some commutations like P53 could be a detrimental factor for our patients, so this is important to remind. One of the problems that we have with lorlatinib is the toxicity, and several doctors are a little bit scared about the toxicity of this drug, but I will say that if we are looking, for example, the hyperlipidemia, the majority of the patients were managed, and if we are looking, the grade 3 toxicities are not so high in the different toxicities, hypercholesterolemia, hypertriglyceridemia, edema, and also one of the most scared, I will say, is the CNS side effects. That could be also some behavioral changes in the patients. But if we are looking, the grade 3 toxicities were very few in this specific analysis. In the profile, in the safety profile, if you are looking the dose reduction and the dose interruption is minimal, and the majority are resolved. Most of the CNA, as I say, were grade 1 and 2, and the CNAs did not require medication. So we can be obviously, we can trust in the drug, we can trust in the management of the drug, but we need to educate very well the patients, and we need to follow very well the patients for these kind of side effects. Some of the problems that we have nowadays are the mechanism of resistance of different alterations, and ALK is not an exception. There are some drugs, that this is a new drug that was coming and presented in ESMO this year, that is the NLV 655, and this is a selective ALK, very selective, more than TRK because it's a pan inhibitor, but it's not very selective for TRK, so we will not use this drug for TRK inhibitors. But if you are looking specifically for one of the mutations, that is the 12CR, that is one of the common mechanisms of resistance, is very high in the coverage. The IC50 in general is very high compared with the coverage compared with the other inhibitors, and also the penetrance in the brain is also superior compared, for example, with lorlatinib. In the ALCOV-1, that is a phase 1/2 trial, this in patients with ALK positive, this is a busy slide. Conclusion of this: important activity, overall response rate, impact also in progression-free survival, impact also in brain metastasis. So very good opportunity for our patients to use this drug. Also, we have some news in small cell lung cancer that I think is very important, and that's the last part of the talk. And we know that the Adriatic was presented this year in ASCO, is the first part, that is a randomization of durvalumab versus placebo, the third arm of the drug. We don't have still the data of durvalumab, tremelimumab. The dual primary endpoints were overall survival and progression-free survival, and that is in patients that are obviously unresectable because we are not operating small cell lung cancer, but it's stage 1 and 3, ECOG 0 or 1, and were permitted also the prophylactic cranial irradiation in these patients. Also interesting to see here the overall survival at 37 months duration of the follow-up of these patients. We see that there is an impact of 55.9 versus 33.4, and a hazard ratio of 0.73, sorry. And you see there a very nice division curves, something at least that is coming for a small cell lung cancer positive, and also in the progression-free survival, 16.6 months compared with 9.2 months. So it's interesting that have an option after we finish the chemoradiation for these patients. If we are looking for the subgroup analysis, there is a benefit for ECOG-1, obviously, and the time from the chemotherapy to the randomization. So in patients that are, and that we saw similar what we saw in durvalumab in patients with non-small cell lung cancer, we need to start quickly the radiation, after radiation, the treatment. So this is very important that we have a very good communication in our institution to don't delay the starting time. So in conclusions, we see that there were in the three congress, ASCO, ESMO, and World Lung Cancer, were a lot of information about neoadjuvant and early stage and perioperatory treatments. Osimertinib is effective, and that is a change of paradigm after chemoradiation in non-small cell lung cancer. The new TKIs for KRAS 12C are coming, so we need to see what happened in first line, what will be the future for these drugs. There are several trials in combination, profiting different mechanisms of actions, including immunotherapy. There are also new antibody drug conjugates that are coming, specifically in MET and in other areas. I didn't have time to speak about HER2. We're not actually very important data this year on HER2, but we know that it's a very nice area of research. And the durvalumab in small cell lung cancer in stage 3 was also a very important addition so that we have for our patients. With that, I thank you and happy to answer some questions. Thank you. A lot of information.
Well, thank you very much. It was definitely a great presentation with a lot of information. I open the for question session. Go ahead, please.
Yes, so again, a tour de force. You really covered a lot in a very short time. I commend you for that. My question is about the ALK space, where obviously after Crown trial, very impressive, unprecedented efficacy results, but a lot of toxicity. And you correctly pointed out that crizotinib is not what we are really comparing it against in our day-to-day practice. So in your daily practice, have you switched to lorlatinib as your first line, or do you discuss it as one of the options?
So this is thank you for the question. It's a very interesting question. I think when we have the data, that we saw the data there in the Crown, we cannot close our eyes and say, no, I will not use it. So I think it's a very good opportunity we use in patients and discuss in the patients. But I say, you need to have a very good team discussing with the patient the toxicities, educating the patient properly and the family as well. And as soon you see some changes in behavior, that is the most important area, you can address that immediately. But I never saw in my patients that I use lorlatinib, even in second or in third line, I never see any toxicity. I remember with the data of lorlatinib when we saw the first time in third line were really positive, even in third line. So this is talking about a very active drug. So these data are really confirming that we have that option and we can use it. I don't know what you are using in your consultations. Are you using also in first line?
Yeah, I felt that by using first-line lorlatinib, it can maybe suppress the resistant mutations, just like how they did the T790M was suppressed if osimertinib was used early on. So I've had a few patients on it now, and so far I feel, as you said, if it started first line, maybe their CNS toxicities are a little bit more manageable and lesser for sure. So I don't know.
I think similar to you, I talk to patients about the data and the promising results with the lorlatinib, but to be honest, many patients are leery of this. Even if you say there's a 5% chance of psychosis, they're like, oh, well, I'll take the other one.
Exactly.
So you have to educate them in a very kind of holistic way.
Yeah, and now we'll be challenged actually in general in targeted therapies because we came from a history. I remember when we did the first study that we published, the erlotinib, and in Lancet, the ERTAC trial, and was a very good opportunity to go for oral medications. And now we are back into the patient and say, no, we will add chemotherapy as well, and maybe we are going. So we need to be very careful how we are handling the information as well with the patient because we will change the paradigm soon, I think.
What do you use, MJ?
So I think that sadly enough, nobody's going to pour resources into the sequence question, which is very important.
Yeah, absolutely.
Because G1202R is a problematic mutation that lorlatinib covers. And there could be some value, since we are still theoretically not curing anybody, even though the survival is long. We know that immunotherapy cures patients, but TKIs don't. Yet in the metastatic setting, in early stage, we have positive evidence now. So I think there's room to give a better tolerated agent, such as alectinib or begatinib first, because their benefit lasts a very long time also, and then keeping lorlatinib in reserve. So far, I'm willing to use that approach rather than lorlatinib.
Yeah, and also, for example, using more biomarker for follow-up the patient. So, for example, the use, I know that you will say you are a fan of liquid biopsy. Yes, I am, but I think liquid biopsy in this case, the follow-up of these patients by liquid biopsy can help us to distinguish which population are able to continue and to have a better response, and also the sequence as well at the end, no? Because it's a big opportunity. It's a good problem to have, different drugs and different opportunities, but it's true. The sequence is a question that we start from the first crizotinib, alectinib history.
Mm-hmm. And my last question is, a patient with neoadjuvant chemoimmunotherapy who achieves a CR, do you still give them balance of the year of immunotherapy, or do you think that you can stop at that point?
That's a very good question. So if you have we don't have data to say I will continue, but it seems that the data that are in direction that you can continue for consolidation in some patients. Mm-hmm. My major question is what happened with a patient who have not a pathological complete response, and I continue with an adjuvant using the same drug that was not receiving a benefit, complete benefit. Mm-hmm. So that is the area that I'm a little bit more struggling for responses.
But obviously you don't add anything at that point.
Exactly.
Yeah. Unlike breast, where we try to do something more.
Exactly.
Okay. Thank you.
So just staying on the same thing, so have you or would you consider alectinib or any of these ALK inhibitors after, just like Laura, extrapolating from that after chemoradiation, maybe if someone has ALK mutation, you have that there?
To be honest, I was having some cases that I was doing some years ago.
Oh, really?
Because especially I remember two cases that there were very young patients. I have my first young patient was 21 years old. And she had a stage 3 and a ROS1 positive. And in that patient, we did chemoradiation, and she continued to have persistence of disease. And obviously, we discussed with her, and the data were negative. And the idea that we had receiving immunotherapy for that patient in advanced disease were almost negative. Right. And so we discussed, we asked for a special authorization to our IRB, and we treat her with, in that case, was entrectinib. And she had a complete response, and is still in complete response because I'm still in contact with her. She's studying medicine, so it was a very nice history. And the second patient was a patient with a ALK translocation that I also discussed with her after a not complete response in chemoradiation. She have still persistent of disease, and she have in the liquid and in the tissue biopsy still ALK. So we went for alectinib, and she was in a complete response, and is still in complete response. So this is our history of success that you see. Yes, we are not curing patients, but if we can impact, so giving a a drug, and that I think also back to the liquid biopsy. But if in that cases, and there are several studies showing that the patients have not a complete clearance and you are giving immunotherapy, you can have a benefit. But if they have complete, talking about not targeted therapies, but if you don't have still a complete, if you have a complete clearance of the ctDNA, these patients sometimes they have not a really difference in benefit with others. So I think we need to establish better, and I hope that we have answers and studies quickly for all these trials, for all these targeted therapies. No, that is really important.
Question about oligometastatic disease. Really, actually, I believe, even when you use TKI, when you convert the patient from multi-metastatic disease to oligometastatic disease, if you hit the remnant disease that does not go at 6 to 8 months or something like that, you may achieve CR, and you may achieve actually, long-term. I have many patients in that situation. So, and that's probably peculiar to lung cancer specifically. I know that may not apply to breast cancer and other diseases, but I think oligometastatic disease does not get enough attention, whether it's upfront or when you convert the patients to oligometastatic disease down the road. How do you manage patients with oligometastatic disease?
So it depends obviously because also oligometastatic disease have different definitions. So if it's a patient who have an oligo up front, like you say, or patients that we are doing a very good response and we keep a very minimal residual disease that is still metastatic, or they are having, for example, after a TKI, a very good response and they progress in a very unique area. So what we are doing is putting in context the treatment achievement that we have with this patient. For example, if we have a very good control in general of the disease, and we are also only facing one area, we can go there for local treatments, including radiation. That's what we are doing, for example, in EGFR or in other targeted therapies. But in patients who have oligometastatic disease, but they are the time of and that was happening during a treatment, and the treatment was, they didn't have a very good shrinking of the tumor. That is maybe we are treating as a systemic and changing the treatment in some cases. So I think the definitions are different according to immunotherapy, to targeted therapies, and the disease response that they have on these treatments.
How you see the different responses, when do you biopsy? I have seen all the spectrum of biopsying, somebody on TKI and being small cell lung cancer. I have biopsied somebody who did not respond good and end up having squamous cell component in the so one has also to think about the response pattern, and I have patients who got crizotinib and had one lesion would not go away 3-4 years with PET scan positive, so we even had to do lobectomy because it was like, and he was in CR for many years actually. I mean, now it's almost 10 years he's in CR. And then we have patients who's 24-year-old that actually experience all the TKI one after another, and based on the approval in the market. So he was in crizotinib first, then then when he progressed, he has. It's there's a spectrum, and I think there are two types of patients with ALK: those who are young and those who are elderly. They behave differently.
Yeah, and actually, sometimes you have, even if it's the small area of metastatic disease, you can have a shedding patient that you can see the mechanism of when you are not able even to biopsy. In ctDNA, you can see the mechanism of resistance. And some patients, we published a series of cases with 797S in EGFR mutation, that we saw that some patients are having not control with the radiation even. So when you are doing a radiation, they have continued the clones that are very, very aggressive, and they are already traveling, and these patients have metastasis immediately, and you need to back to systemic treatment.
Have you noticed more radiation or I should say pneumonitis in small cells, especially for 2 years of immunotherapy? Like, I'm just talking about Adriatic trial, just like a Pacific
Yeah, I
had
was
some.
not using a lot this, but obviously radiation is giving this kind of problems, no?
Right.
And there is always the question if it's tumor, is radiation, is radiopneumonitis, or is infiltration of lymphangitis. So that's always the questions that we have. What I'm more concerned in ILD is in antibody drug conjugates.
Oh, yeah.
There I have my concerns because it seems to be very different compared with the immunotherapy, the mechanisms that they have. So in immunotherapy, you have suddenly a patient that became radiologically active and even symptomatic in the majority of the time. But in ADC, since that is an accumulation over the time, we are working now in a meta-analysis to see what happened in the ADC compared with immunotherapy, but it's the kind of things that we need to educate very well our radiologists, because in radiologists, the radiologists say a small increase of reticular patterns so compare with the first one. But they are not comparing with the baseline right. Sometimes. So, and this patient, when they have with ADC pneumonitis, is much more difficult to be solved with cortisone like we are doing with immunotherapy.
Great. Just one more question. I thought the Harmony 2 trial was also a real highlight of World Lung. And to my knowledge, this is the first drug that has beat Pembro head-to-head in the first-line setting. But there was a little bit of a problem in that the patients enrolled were all PD-L1 positive patients.
Yeah, that's more than 50%.
And basically the KEYNOTE 042 population, which is not how we would normally practice here. So just any thoughts on that and how it may have impacted the results? No,
that's a very good question. That's a very good comment. And actually, I forgot to say that in the slide, several data. But yes, they put the 149 and more than 50. So we are waiting for, it's very fascinating. Obviously, everything that is coming from outside, you are always looking with a different eye. So we are trying to get the data, and the company is trying to get quickly this data. The trials that they have now is in squamous, and they have also a trial that is specifically with EGFR, because they have a population in EGFR that was positive with this. Maybe it's the component of the VEGF. But we need to have the data in our population with a better understanding of our clinical practice that is different than in China.
Great. Well, we can keep you all night here.
No,
but I think
I need to drive home.
Yes.
Thank you very much.